Nice background.
I'm not sure which beach this is.
Looks like it's a good one to be on. How's DC doing?
Good, busy. What's happening around here? Definitely getting hippity hoppity for sure.
Yeah. I feel like what should have been, I feel like we're getting to the time of the year that our stuff should be slowing down for like natural like thing to summer, and everybody's gotten out and sharing all their diseases, and so it's giving us volume when we didn't have the same volume.
And I mean, school will end, whatever versions of hybrid are happening here will end in 4 weeks, but apparently I guess our rates are lower, that the state, which has actually been pretty conservative overall, is opening up, I think the end of this week or next week, like restrictions all done. I mean, masks, yes, but no more capacity restrictions inside or outside. So that should make us busier too.
Yeah, our governor in his brilliance just pulled off mask mandates and said it supersedes anything that local school districts had. So as of, I think it was Tuesday, I think Tuesday, our kids are no longer required to be masked. That we had to have a conversation with our 5-year-old, like, you're still wearing it. Like,
oh, that's so hard.
You're still wearing it because
That's
they've got
so
a bunch
hard.
of classes in quarantine, and like their numbers are whatever. So
yeah, especially for the small ones, they're like, but he's not wearing it, how come I have to? That's so hard.
I mean, I will say I expect at the beginning of all this, when kids went back, I saw like memes of things of like, kid goes to school with a Batman mask, comes home with a Spider-Man mask, and like swapped with a kid, and like it was going to be awful. And he's been really mine has been really responsible with it, but we'll see.
Hey, Matt.
How you doing, Henry?
Good. Thanks for presenting today. So we'll give everyone till 1:05 to come in, and then you can get started. The one thing I didn't think about, Matt, is that I don't know if a lot of people are attending the SAEM conference that's happening this week, the virtual conference.
I joined PAS, but I didn't join SAEM.
Yeah, because actually we just presented yesterday, so I didn't think of that. So
yeah, that's fine. I admittedly, like, once conferences all went to virtual, a lot of them sort of went off my mental radar, even though it would be obviously easier to do them.
yeah, I know. Yeah, so it's something I'd also keep in mind. But it's 1:05, so good afternoon, everyone. Thank you for joining us today. Today, we're going to have Dr. Moake from South Carolina presenting to us. So Matt, thank you again for presenting, and you can take it away.
Cool. Let me we go. I get my screen sharing here. All right, can you see that?
Yeah, you're good.
Cool. All right, well, thank you, everybody. So like Henry said, I'm Matthew Moake. I'm here at the Medical University of South Carolina, which is in Charleston. I see we've got the Grand Strand crew, which is up in Myrtle Beach. And I'm going to go over sort of a kind of a semi-themed potpourri of cases for the day. First two cases are ones that actually was not the scanning person, but I got phone calls from our current ultrasound fellow who is EM trained, PEM fellowshipped, and now doing an ultrasound fellowship because he just wants to keep doing more fellowships. And so these are ones where he was in doing scanning shifts and wanted to get some real time input, which is something we actually do a fair bit amongst our ultrasound crew, kind of between texts of photos and whatnot to get secondary interpretation from our crew. So the first one was a 3-month-old late preemie coming in with 4 days of emesis, fatigue, decreased PO intake. Mom notes that he was starting to sweat with feeds and had pretty much plateaued from a weight gain side. And the kiddo was a twin, and families sort of reported that the kid was always the lesser of the two when it came to POing, but that had really become pronounced over the last little bit. From initial exam wise, his vitals as recorded initially were not particularly impressive. He was noted to be irritable. The actual exam itself says the kiddo was tachypnic with some nasal flaring, retractions, but otherwise clear breath sounds. They noted a harsh 3 out of 6 holosystolic murmur over his left lower sternal border, 2 strong femoral pulses, and a cap refill that was about 3 seconds in their exam. And so ultrasound fellow went and did a cardiac POCUS, given the concerns there with the feeding, weight gain, and all that sort of fun stuff. This was his parasternal long view, and it's a bit more towards the apex than would ideally get. And so he basically called me as he's like getting these images so I could look at them. And this was like at like 8 o'clock at night or something. So pulled him up and looked at this and was pretty quickly struck by general size of left atrium here. And sort of that really dominated the screen from what we were looking at, and sort of drew eyes away from the fact that really the whole left side of the heart was rather enlarged in this shot. And this is like, again, a fussy 3-month-old, so you're getting kind of clips in and out from great views. And that's a still on the right. Swung over to the apical 4, which sort of put the anatomy, I think, in even better context and really emphasized just how big the left versus right heart was. You're kind of floating between the apical 4 and 5 here, as you can see that aortic outflow kind of popping in and out of view. But really enlarged left side with the left atria just being huge, pushing over into the right side. As we're looking at these and the rest of the images you got, overall squeeze actually didn't look all that bad to me. I don't know what anybody else thinks. You could intermittently see like a trace of an effusion, but nothing that was particularly notable. And general like cardiac, as far as like a 4-chamber anatomy went, besides that enlargement on the left side, looked fairly normal as far as giant septal defects, that sort of thing. This is his subxiphoid view, again, really just emphasizing that whole left heart being quite large, but you can see fairly clean atrial septum. Intermittently where the ventricular septum comes in, it looks fine. Intermittently sort of a very trace effusion, but nothing particularly impressive. And again, a squeeze that didn't look horrible, maybe a little bit down. So he narrowed down a little bit, and this is sort of back to, this is sort of in and out of his apical 4, looking at the mitral valve for regurgitation, given the murmur and the size of things. And, this is a lot of movement, but pretty large murmur going on, or effusion, regurgitant jet going on there. This, he actually swung over to an apical 3 to get a little bit different view of that. And you can see, a large jet coming back with sort of a posterior direction to it, a little more eccentric. And this certainly makes sense given the dilation of the left side of the heart. So they pretty quickly got some labs going on this kiddo. Had a metabolic acidosis with a lactate almost to 8. Had a BNP and trope that were both up. Chest film, which I'll show, showed cardiomegaly, EKG, which sort of matched to the echo findings of sort of biatrial and biventricular enlargement. They got a quick cards consult. The cards fellow came down and did an echo themselves. And sort of the read on theirs is pretty much identical to the point of care from what we could see, with a lot of limitations. They didn't assess arch and lots of other things. And as I was having the phone conversation with him, my thought was, this looks obstructive on the left side, and could this kid have a co-arc? Obviously, a little later than we usually see. The kid had just turned 3 months, and by our report had good femorals. And then later on in the stay in the ED, they did upper and lower pressures, which looked fine. But the following day, they got a formal cards echo, which looked at all structures, and they ended up having pretty severe postductal co-arc with, I think, a gradient of like 41 or so. And then otherwise, sort of the similar findings that we had. So that left-sided dilation, pretty bad MR, and the slightly decreased LV function. Here's his EKG, which I will never claim to be a master in EKGs, but even this one sort of jumps out to me from some of your lateral lead QRS complexes and some pretty darn big P waves. And then a chest X-ray, which certainly doesn't look normal. So this kiddo got admitted to cards. They started him on sort of, volume relief, milrinone, did some high flow, ended up not needing to intubate him for respiratory support. They tried prostans on him, but he wasn't responsive to them because he was postductal. Ended up going to the OR for primary repair thoracotomy on, I think it was his second or third day. Got intubated from OR, but quickly extubated, and actually did overall quite well from an operative course. Ended up going home about 2 weeks later. He actually was just readmitted here recently for some like poor PO and weight gain, which they're still working on. He still has some residual left-sided dilation and some residual mitral pathology, but his co-arc repair looks good. Any thoughts, comments on that case?
Just a quick question on any of the long axes, like how thick was the LV?
How thick was LV?
Yeah. I mean, I don't know. I guess you kind of get a sense of it on the Ford chamber.
Yeah, I mean, he didn't measure it. It didn't look particularly like from a muscle hypertrophy wise, didn't look too bad. Chamber wise, he didn't take outright actual measurements, but certainly from just like the ballpark.
I mean, that's pretty interesting having, a co-arc level of obstruction.
Right.
And EKG looked like big time LVH, but
the muscle wall itself. Yeah, no, the muscle wall itself, it says, and it's only at 3 months. So my guess is this kid was close to, sort of reaching kind of a critical period. And just luckily got caught at the right time. All right, next case, a little less interesting, although I'm kind of curious to see how aggressive people would have followed this. So this was an 11-year-old girl, history of ADHD, anxiety, and some migraines, who came in, was actually seen at her school nurse for a sensation of tachycardia and palpitations. Nurse supposedly listened to her, counted out her heart rate about 140 and heard a murmur. Had her rest for a while. 20 minutes later, was still getting the same heart rate. So sent her over to the ED. And of course, by the time she was at the ED, she felt totally fine. And she and her mom were both saying they probably just thought this was an anxiety attack. And so same fellow was there doing a scanning shift. On her exam, she had pretty interesting vitals again, normal respiratory exam. From a cardiac side, he felt that he heard a diastolic rumble to her. The officially documented note, because he was there just scanning, so not actually doing documentation per se, was that there was no murmur. And then she had good peripheral pulses and perfusion. Here was her EKG that got done. Nothing particularly, here. So here's your parasternal long axis. So older patient, much more compliant, a lot more classic view. Anything that sort of stands out to folks on this shot?
There's something on the valve, or?
Yeah, so
sort of little ball.
yeah, and that was where my eye was drawn. So, grossly normal size, no effusion, sort of, if you kind of run sort of 3 fingers off the LV, everybody looks roughly the same size. Gross squeeze looks good. If you were to try to EPSS, that valve is hitting, but that valve looks awful chunky. Girl had no sort of history to, no known valvulopathy, anything like that. Threw some color flow on. In this shot, you can certainly see not a particularly impressive, but a little jet sort of coming off there. So some mitral regurg, which could certainly correspond to the some of his exam stuff. Parasternal short view, actually didn't really add much for me. The one side looks a little bit odd to me, but I think it's probably more a matter of just how he's cutting sort of papillary versus starting to get an accordion and whatnot. Swung down, you got an apical 4. And on the left is sort of the full field off of the phased ray probe. And on the right, he sort of narrowed, this is still the apical 4, but he narrowed the sector down. And I don't know, I will say I don't particularly do this very often, but it's certainly a nice little trick to keep in mind that I assume most machines, and my exposure to various manufacturers is a little limited, but you can narrow that sector plane down so that you can narrow, increase the beams that you're hitting on a single spot. And it gives you a lot prettier resolution for what you're looking at to kind of tease out, am I seeing some little subtle artifact thing versus not? Sorry, I just saw a comment. Right, and so here, certainly this view doesn't look quite as prominent, having sort of that little bump on the valve. Through color flow on here, and then so especially with that narrowed sector, you can really make out that regurg a lot better, and start to kind of identify the actual anatomy of the regurgitant better. And so this is in the window we were doing sort of deeper dive cardiac stuff in our fellow curriculum. So he nerded out a little bit, zoomed in and tried to start like breaking down the jet anatomy. So we actually took measurements on convergent zone, your vena contracta. This is sort of kind of one of the ways you can grade out MR from the Otis text. And so for he's got his vena contracta at about 0.3, which would put him into kind of the moderate range. And I'll say I don't ever really bother to do this anymore after like doing it critically when we were doing that sort of curriculum. But my general gestalt is if I can actually make out the multiple zones in the jet, then it's probably at least moderate. And again, from a symptomatic side, she seemed totally fine on the ED. Here's an apical 3, still kind of trying to get more views of that valve. And here you sort of back and forth to seeing a little bit more of that kind of thickened component to it, not visualizing that jet quite as well. So from a workup and course wise, they ended up consulting cards based on this. They of course heard no murmur on their admitted exam. He had made their images available to them, but it sounds like they didn't even bother to look at them. They advised discharge and plan for follow-up in a couple of weeks. And as of now, and this was back in, I think, January, she's not followed up, done anything. So fairly ungratifying. And I don't really know if there's anything of significance there, or just sort of a incidental from a scan shift. We would have liked to see something a little more with it. Cool. So next couple cases. So I got a little bit of a meme wormhole this morning, but and found this to be particularly pertain to these. So the next two are both kind of foot procedures, injuries. So this third one is a 15-year-old healthy female coming in with an abscess on the sort of the left, kind of like basically MTP at her small toe, at a site that she said she had to work for effectively years. She'd been seen in urgent care, started on Keflex, which wasn't doing the job. Actually had an outside ultrasound, which the parents got the report of, and they talked about this like vascular mass and needing to come here to get MRI and OR and all this sort of elaborate stuff, but had no imaging and no report with them. And sort of in the days since starting antibiotics, she was not getting better and actually starting to get some streakiness to her left, to the foot itself, but was otherwise like afebrile and well. So here's the yuck on her foot. And it definitely certainly like looks like she's got a fairly kind of classic, little kind of like pinpoint sort of black spot that goes along with the plantar wart, and this sort of like almost like hemorrhoid pillow donut of pus sitting around this thing. We ultrasounded it, and it looked like a donut of pus circling around sort of this, you know, more kind of heterogeneous mass, which I can't say I've ever gone and looked at a wart before, but certainly seemed like that could be consistent with a wart and there's some vascularity to it, not particularly impressive. And so we actually we sort of debated how much we wanted to do to this versus just sort of drain it versus how aggressive we want to try to get things out. Ultimately decided that we definitely wanted to drain it out, and the best way to numb it would be a PT block. So this is her tracking up kind of the anatomy of her PT, going from sort of a distal up the proximal, so the nerve's sitting here. And this is sort of moving up kind of just proximal to Achilles, sort of aponeurosis. Came in, and so on the left, this is sort of the initial needles come in, injecting here, kind of right at the nerve. And you can start to see kind of a nice field of fluid developing, sort of hits that plane that starts spreading around it. And then here on the right, we subsequently kind of redirected, and the nerve's a little bit hard to see here, but we're now above it, injecting in and around. And so with this, let her sit for 10 minutes. You know, the baseline pain she had went away. We're able to sort of knife into a couple points, drain that out. And we initially intended to just sort of get out the pus and leave a loop in. And as we were going about it, we found that we were basically kind of blunt dissecting out this sort of wad, which was presumably this massive wart. So she got herself an IND and sort of a ED-based plantar wart removal, which the family ended up being quite happy about. And I was a little leery that once we got to sort of this very kind of lateral aspect of the foot, we're going to kind of run into a little bit of pain. She did have like a little bit of sensation once we got over there, but tolerated it very well, and really had no sense that we were doing anything more to the middle of the foot. I follow up with all of our blocks, and she was almost completely pain-free the next day. And the family we texted back and forth for a few days. So as I was kind of following her, the wound out, since it was a little bit of a weirder IND in an odd spot, she followed up with ortho, and everything was doing fine.
What's your cocktail of block that you use?
So we just did Lida with epi on her, largely for convenience. I have not yet, because we have that just like sitting on a shelf, and I can grab it without ordering it and sort of go to town. I've got, we can order ropivacaine, bupivacaine if we want, but for stuff where I'm just sort of, proceduralizing and being done, I've not bothered to go with those longer acting. Are a lot of sort of the blocks that we'd want to do for like longer lasting kind of like admitted pain control for like leg, femur fractures and stuff. Our adult colleagues will do typically a mix of like lido and bupivacaine or lido and ropivacaine. We actually just recently did one on the ped side recently. Our ortho folks have been very resistant, but they sort of gave us the go ahead on one recently, and we did lido and bupivacaine on that, and that one worked great. Similar kind of case, just kind of emphasizing the point. It's a 7-year-old who stepped on a needle a couple of days before, came into us with an x-ray that showed said needle sitting right in there. I will say I often find these to be very hard to find ultrasound-wise because they're so bloody small, and they don't give a lot. I don't find they give a lot of kind of classic reverberation to them. I was actually able to find this one in his foot, which was nice because our EM residents had gone in and couldn't find it. Near impossible for me to be able to consistently pick it out when I went to transverse, which would have been ideal for removing it under ultrasound. So we talked with mom quite a bit and sold her on the block, and this kid was only 7, so was anxious, and mom was hesitant that it would actually work. So here on the left is kind of a more classic distal anatomy coming off the medial aspect of the mal. Nerves here, vessels are here, and just kind of tracked it up. Again, and my usual approach is to try to get kind of right above the Achilles itself, so we can come fairly clean in to maximize sort of our resonance off the needle. And so here's where kind of the level that we decided to block it out, the nerve here, and then the vessel sitting kind of, this is sort of posterior side, this is anterior side. And here we are, sort of the initial block coming in. lost needle tip there, kind of right at the nerve, was able to kind of slightly inject and sort of get right around, and then got nice spread around.
Matt, where's your profile and what orientation for this in this view?
So this is transverse, kind of right above the Achilles. So posterior calf coming in from here. I think I actually have a shot of our typical approach here in a second. And so this is my more idealized needle visualization with sort of, reverberation all the way down the track of the needle. As the fluid gets in, you can really make out that kind of honeycomb appearance of the nerve, and ended up adjusting a little bit later on and getting some spread up here, and obviously try to get back here where the vessels were. And so blocked in, we used the C-arm for removal, which we had a case report doing this with sort of a very similar case in an older girl. And one of the comments I got sort of knocked on is why we didn't do ultrasound for it. And I consistently find these like tiny little needles to be just such a pain to see. And now we've done a number of them with the C-arm, and it's available to us. So we've got pretty slick with it. But we did this, and like mom was down at the base of the bed, and we had child life up with like a book and the kid. And at one point he looks down, he's like, "You guys will tell me when you start, right?" And we shook our head, we're like, "Yeah." And mom just kind of, his eyes were all big because we had a driver buried way in his foot when he was asking us that. So he had no idea that we were doing anything to him, and popped it out without much problem. And he got to go home right away, as opposed to sitting recovering from a sedation. And so I'm a big fan of the blocks. If I could have just one, it would be the PT block, because kids step on crap. And at least for us down here, like we have a ton of beach injuries, a lot of oyster shells, you get some stingray barbs. The oyster lacks are awful because they're dirty to clean out. They leave junk in there. You got to clean them. I'm just reading Romero's comment.
Just tell you, because I feel like we try to get these needles out in the ED, never mind even from the block perspective, even if kids like sedated, it turns into such a bloody mess, and it's like so in there. I'm like, oh my God, by the time I walk into it, I'm like, holy, it looks like we're killing the kid, because even with the ultrasound there, I'm like, we can't get it and get the surgeons, and I've gotten loath to go digging for needles.
This one actually, so again, we've started doing, I just, the first couple of these that I had, I attempted to do with ultrasound from the actual like digging out, and just, like I can see this one in long axis, but in short axis, like that tiny little blip, because my ideal would be see it in short axis, come a little, basically use this to sort of identify where I'd want to cut, and then sort of track in real time and watch, a hemostat or something come in to grab. But now I've actually gotten to where we just pulled the C-arm out, get it in a plane where we can basically put a hemostat right in line over with this, come a little back, make an incision. And this one probably took us 5 minutes to pull out with that. This was definitely the slickest of them so far. I've definitely spent a good bit of time with sort of me digging, and the C-arm giving us the little buzz that we've exceeded the amount of time we should be irradiating somebody. But it's definitely gotten more comfortable. And it's one of those, like, we could do it, but it's kind of one of my little joys to be able to actually get to play with. So this is our approach, and this is a figure we had in that paper. So we'll come in pretty with this, kind of start tracking down here at the mal, and then walk up until nerve gets into a nice plane to be kind of right at level of like Achilles aponeurosis of soleus. And we can come in ideally at a fairly clean, almost 90, so that we get sort of, maximize the anisotropy off the needle. In a very timely manner, ACIP just popped this one out, approved back in April, sort of effectively, and I kind of have highlighted here saying that ultrasound guided nerve block is not only within our purview, but should be part of our expected practice. So it's definitely one of the things that I've been trying to get. I think we've talked before, there's a balance of kid tolerance and sort of ease of sedation that we can do, but I think there's definitely it's one of those, the more we do it, the more comfortable we'll get with it. And like our nurses now, if I say I want to sedate somebody, the room's set up in 5 minutes. If I say I want to like set up for a block, nobody's going to help for anything. But I think we can slowly change that.
Matt, in your experience for the younger kids or for the ones who are more anxious, are you needing to numb the skin as well, or you feel like they tolerate this without just with the block?
You mean numb locally at the foot
Exactly,
or
before
numb
you,
locally?
before you do your block, yeah.
So this kid we did freezy spray on.
Okay.
Usually, honestly, like this, I mean, this is my standard setup with a 10 cc control syringe and a 27 gauge. It's like 1.5-inch needle. I think it's really more, I think actually the needle in itself is not so bad. I think you get that little burn from the lidocaine, which tends to be, they're bigger. I will usually do a little topical wheel and then sort of go in. I will say just anecdotally, like I have all of our fellows block me. And that's going to be, I think, the first Tuesday in June this year. And like, this really is, it doesn't bother me at all. Kids, this kid was 7. I think I've done as low as 6 to be able to kind of get him still. And he had child life, had mom at the head of bed for the block. Like he definitely like cried with the block, but he sort of started crying before we did anything to him. But we were able to hold him pretty still. So we're able to see the needle really well, as opposed to, this like moving landmine from an injection stance. I think probably I'd aim more for like a little P over said beforehand. But him, we just did some freezy spray and went with it.
It's great. Yeah, I've done it once and it worked really well, but I'm just thinking for the smaller kid, I like hearing your technique.
Yeah, I think, I mean, the angst component of these are always going to be limitations, I think, with all of the regional stuff, because you got to get them hold still for your needle to go in. And if you've got to be able to have a clean enough field to, have an in-plane approach or even honestly out of plane, you can only do so much holding still. You obviously can do most of these as an out of plane as well, which might give you a little more wiggle with sort of needle visualization. This one I always do in plane. I've done saphenous out of plane just because there's not really much to see, and so I just drive down to the vessel itself. But it's definitely one that I'm a very big fan of. I know Zach had presented one of his cases of this before too. All right. Next few cases were actually like a series of patients that were in a very close time frame, 3 of which were in the same shift. So case 5 is a 4-year-old male, history of a heart transplant. It was a couple years prior, was due to dilated cardiomyopathy post a co-arc repair. He previously had a Berlin before his transplant. And he came in with this sort of complaint of constant left-sided oblique pain. And sort of mom described it somewhere in the evening, he started kind of grabbing his left side and was sort of like holding it and saying it hurt. Nothing really going with it as far as like PO avoiding stool changes. It was afebrile. They put him to bed. And this was sort of fairly late in the evening when he started. He woke up several times, tossing and turning, still complaining about it. Dad was an EMT who like listened to him, thought he probably just had gas, and he kept at it. So he came in. And when asking mom if there'd been any trauma, she's like, no, but he was with his older siblings playing go-karts in the day. So it's like, I don't really know what we have here. His exam was very uninteresting from like a focality perspective. He was mostly sleeping, would like maybe wake up because you were poking the left side, or just wake up because you touched him, but then would fall asleep during the same period of palpation. Nothing that was palpable, like nothing that really like stood out. Kind of the most notable thing is abdomen was just like covered in old surgical scars between G-tubes, surgical sites, the Berlin site. And so really had no clear sense of if this was real at all and what it was. So started out with just sort of at a soft tissue level, kind of panning over some of these scar sites in the skin to see if there's anything kind of collected looking weird. This is sort of right over his old Berlin access site here. So just a bunch of old like scar tissue, nothing that stood out to me from a, fluid collection, abscess, cellulitis, and nothing on a superficial exam really would put a point to that. Similar here, kind of soft tissue in that area, a few areas where you've got this sort of scar tissue that's sort of given some artifact. Some very unremarkable looking bowel, sort of deep to that in the abdomen. And so didn't see anything on the superficial side, figured kind of where he's putting, it wasn't really like any focal CVA tenderness, but this sort of left flank pain, figured look at the kidney, see if we saw any signs of hydro, evidence there might be stone going on. Went to look at the kidney and so this is your left upper quadrant, kind of classic renal fast view. And kidney looked fine to me, but something looked fishy. Any takers?
Was that sitting above the upper pole, the kidney?
Yeah, so I kept seeing kind of this glimpse of these two little
Yeah.
things in the spleen, and so adjusted positioning a little bit to focus more on that. And they had these two, pretty circular stuff that looked like they were sort of, lesions in the spleen that had this very interesting like halo of like hypoechoic tissue with surrounding what looked, pretty similar to the splenic tissue itself. A little one gave us a little bit cleaner picture, but looked like sort of two of the similar, one bigger than the other somethings. Measured them, one was a little shy of 4, one was a little shy of 2 centimeters. Looked at them in transverse, and they were sort of very regular and round. So little guy here and sort of the big guy sitting in that inferior pole. Both definitely look to be, intra-spleen. Through color flow on them in both, and our machine's been giving us a lot of funky artifact, but as he was moving, but clearly vascular, and it looked to be more like vascular, more heavily vascular around than the actual mass itself, but certainly had some, bits of vascularity to it. And so looking at this, looked with the linear as well, just to see if I could make out anything, more useful with it, and, a little bit cleaner tissue architecture, but still pretty similar looking to that kind of internal component of whatever this was. Looked a little bit more different than the rest of the spleen tissue did. But, two little nuggets of something. So followed up with a radiology ultrasound, which, added nothing. And so it was confirmed what we saw. My concern and their concern when we looked was, kid on was on immunosuppressives, and it was something in the spleen. Could this be some sort of like post-transplant lymphoproliferative disease? Got a smattering of labs, which were interesting. Talked to the cards team, and they're like, we don't know what to do, but certainly wasn't present on prior imaging this kid had. Totally unclear to me if this was actually a source of his pain or just sort of an incidental. I certainly could imagine that, if this splenic capsule is being irritated, that it could be a source of pain. We ended up admitting the card so they could sort of flush out what they wanted to do from an imaging and sort of further workup side, because he was totally stable. CT basically confirmed that he had the 2 masses there. He also ended up having a bunch of like small micro nodules in his lungs. So they biopsied it and ended up coming back as spindle cells consistent with an EBV-based smooth muscle tumor, and effectively a variant of post-transplant disease. He ultimately ended up going a splenectomy and started on sirolimus for that. Thinking maybe a totally dumb luck find, but and again, I'm totally unclear whether that was actually the source of his pain or not, or if he was just a 4-year-old who had a good day on the go-karts and was a little sore. Next
It was
case.
a source of pain, right? Like finally it stretched to a point where it was like,
Yeah.
all right, now it hurts, because it's so bizarre that he's saying it hurts on that side and you found the thing. So I would go with 1 + 1.
So it was one of those like blind squirrel, I'll take it. Cost the kid a spleen, but probably needed to happen. Next one, this kid was very interesting looking. So it was a 12-month-old who had no like established significant medical history, came in at the bequest of his PCP for some vomiting, decreased activity, and fever. And he basically had started vomiting that day, taken to his pediatrician's office, and like was vomiting and looked kind of sick there. So they effectively called EMS to the office and sent him in, and he had some more vomiting with EMS. He'd had normal stooling, was having decreased PO, so was decreased voiding with that. And while he didn't have anything established, he was actually due to be seeing the endocrine docs in a few days later, because they noticed that he was sort of viralizing and developed pubic hair. And so there was concern that there was something amok on that front, which obviously makes sense. His exam-wise, he was febrile and appropriately tachycardic. The rest of his vitals weren't particularly interesting. He definitely looked uncomfortable. When you looked at him, like you could definitely tell there was more sort of masculinizing hormone going on him than there ought to be. He had sort of a kind of a heavier brow and a little bit of a mustache, probably the point that I was at when I was like 22, which doesn't necessarily say much, but and then from a respiratory side, he's just like kind of sitting there grunting, just kind of like a and lungs were clear. And looking at the rest of him, it didn't seem that the grunt was probably respiratory, but more the fact that his belly was just distended and rigid, diffusely tender, and you really just couldn't poke in anywhere. So you couldn't really tell if there was any like focal like enlargement mass, that sort of thing. And then he had like some pubic hair, and I don't remember the exact Tanner staging. I actually came into him after they'd gotten some initial labs, and they were like, let's go ultrasound. And I was like, cool. Interesting. Mom was like, this is the way his belly always looks after he's fed. And mom was just like taken aback. And apparently grandma had been like, his belly's not right. And so they had gotten labs on him, most notable for elevated AST, but normal ALT. And then they'd sent a bunch of the endocrine stuff and tumor markers, which weren't back at the time that we were doing this eval, but his testosterone ultimately came back quite high. And so when I came in, they'd gotten labs and were planning to basically just go ahead and straight CT him because there clearly was something wrong here. And the resident who had him is a senior EM resident who's actually going to be one of our incoming ultrasound fellows next year. And so he's like, hey, let's go look. And so this is sort of left kind of upper quadrant to sort of left mid quadrant, more of a coronal view, and just really sort of nothing, you know, identifiable to me except this big old heterogeneous looking mass. Slid down a little bit more, caudal, you know, couldn't see really make out much in the way of liver kidney in that shot. Could actually find once we got, you know, almost down to his iliac crest, we can make out what looked like, you know, reasonably normal kidney structure, minus the fact that it was sitting way south of where it ought to be, and seemed to be reasonably distinct from the mass. Checking the chat. Swung over, so this is a transverse, so kind of spinous process back here, just taking up the full view. You can make out a little bit of liver kind of in this shot here, but very heterogeneous. I threw colorful on it because it looked like you had definitely like necrotic components to it. This is sort of looking sort of as cephalad as we could to it, so you can actually see kind of at the start of that some of your hepatic veins coming in, almost getting like an early sort of fast shot there. Really sort of indistinguishable to me from where sort of liver stopped and this began, and whether it was actually emanating from liver or not. You know, I guess from our perspective, doesn't really make much difference. At this point, it was kind of more just curiosity. Here was sort of the best we could get on measurements of it. So, you know, 12 by 10 by 10 or so. And very understandable why the kid was grunting and basically, you know, using all of his sort of chest wall and not much in the way of diaphragm because this thing wasn't allowing it. So ordered a CT, radiologist called, was like, you sure don't want to ultrasound? And the attending who was officially managing was like, no, I think we're fine. And so the initial read was actually was thought to be like probably like adrenal neuroblastoma. And then with the labs, the sort of the attending read was more concerned for adrenocortical neoplasm. Admitted him to hemonc. He ended up going a removal of the kidney as well as the adrenal on that side. I'm not entirely sure why they had to take the kidney, because it didn't look to be involved by imaging, but they did. And it ended up being, despite its size, non-malignant, and he didn't even have to do anything else. So mass out, move on with life, basically. And then, so this is a CT. So pretty similar sizing to what we were able to get, you know, fairly clean from the kidney itself and kind of going up into around that liver. Next of these, so this is the same day, same hallway, same nurse. I took a call from a local ED who basically said, I've got a kid, we're concerned about a ruptured appy. So 8-year-old female, she'd had 3 days of belly pain, some anorexia, distension, and sort of gone to school, not gone to school again. Had started developing vomiting the day of. They actually went to an ED like a day prior, and basically the wait was long, so went home. So went to this other outside ED. It was febrile to 38 there. They did some labs with a little bit of an elevated white count. And per their exam, she was sort of diffusely tender, but with focal rebound on the right lower quadrant. And so their concern was an appy. Gave her some Tylenol, Zofran, sent her on her way. So she got to us, she kind of popped on the board and one of our EM interns signed up for her. I sort of gave him the bit that I had gotten from the outside. Vitals for us, afebrile post Tylenol, really not particularly interesting. He went and looked at her, comes and rolled the machine, ultrasound machine, and with him because he wanted to go look for the appy. Described as sort of ill appearing and uncomfortable. and sort of on my exam, definitely matched that. Her belly was distended, but like not everywhere distended, rather kind of like midline, sort of like early gravid distended, very firm. And it was definitely not rebound. It was just hard and generally tender, but not really focal. And so the intern had gone in ultrasound and kind of came out with this image. He's like, she's got a weird fluid collection down there and there's something behind it. And pretty much came out when he saw this, and we went back in to scan some more. And so with that, took a bigger picture view of his sort of fluid collection in something. So this is transverse, kind of right lower, moving more towards right mid quadrant. So big fluid, fluid collection. This is actually bladder that's just being sort of moved out of the way. And then sort of this big mass sitting here. This is sort of more classic kind of bladder view. So panning from caudal to cephalad and transverse. And pretty much as soon as you can get a view proximal to the symphysis, you've just got this mass sort of making its way out with the bladder kind of being draped up and above it. And this sort of, I typically run like 6-second clips, and this was extending to above her belly button before we could get to the end of it. Sagittal view here to kind of get that shot. So bladder kind of coming up on, and just a big old mass. Really tough for me to make out, normal pelvic anatomy and sort of what was what down here. It's sort of a one shot where I feel like I could see a little bit of a vaginal stripe in here, but nothing that I can make out as far as like uterus, ovary, anything like that. Took some measurements, sort of kind of guesstimated on its length since I couldn't get it into single view, but even bigger than the last kids, which was like great. Heterogeneous, looked to be probably pelvic in some origin. Went in and looked at her kidneys as well, given the way that was pressing up on the bladder, and kind of as we were guessing, she had some pretty solid hydro on both sides as well. So did some lab workup, talked to some folks. Her labs were largely uninteresting from the routine stuff. Did some tumor lysis labs, which was like a mildly elevated LDH, not particularly interesting, but her AFP was, unmeasurably high. The rest of her labs are otherwise normal. She ended up getting a CT, which was concerning for a germ cell tumor, and saw what they called, severe hydronephrosis as well. Whereas her CT imaging and sort of the sagittal shot nicely shows kind of how she was like kind of focally distended in this area. And it really was like her exam, like it was sort of midline and sort of running up, which matched where her mass was. So we talked to hemonc, we talked to urology as well, given sort of the obstructive component of the hydronephrosis she had. She managed to go to the OR fairly quickly the next day with the surgical team. And so the mass ended up deriving from the left ovary. And so they took the ovary and tube. The tumor itself actually ruptured mid-procedure, which is semi-unfortunate. And in their evaluation, she also had some like omental involvement as well. So I had to take some of that out. She ended up with a grade 3 yolk sac tumor, and unfortunately has to undergo some chemo because of the tumor extent and some of the operative complications. She did not end up needing to be stenting because they were able to get the mass out and relieve that pressure. So later in that same shift, in the same hallway, we had a 4-year-old female, and this is right around, so our shifts, we have a 3 to 11 person. I was the 5 to 2, and we had a person coming out at 11 o'clock. We had another 4-year-old female whose PCB sent in because they were concerned for appendicitis, and they'd sort of talked to her by phone, and she had fever and right lower quadrant pain. And so was told to come in, and the attending who had the kid with the adrenal tumor and I looked at each other, and we're both like, we're out, like not doing it. And unfortunately the night attending who came on was busy. So the president came out and presented this kid to me. And luckily she was just a normal kid and she did not have a tumor. So we did not have to, we sent her home, no image. Well, we didn't image her, but no tumor that was felt to be warranted, nothing that was felt to be warranted looking at, but it was one of those like, holy cow, I can't do this anymore tonight. So 2 for the night, but not 3. So we got 2 minutes left. Questions, comments, thoughts on any of the tumor cases? Again, not necessarily like the focus of point of care, but some fun images that certainly. All right. So this next one was one I actually had a while ago. It's a 14-year-old male, history of poorly controlled diabetes, type 2, A1Cs that's typically landing in like the 14s range. Coming in because he had 2 weeks of this sort of left thigh kind of groin abscess, well, left thigh groin swelling, tenderness, redness. He said it started as a bump a couple weeks prior, which he was in the shower and popped, and had sort of fairly persistent drainage from it since. He'd had chills, no fevers, and was generally speaking systemically well, minus this kind of chronically irritated spot. From an exam wise, his vitals were fine. He was obese, but otherwise well appearing. He was one of those, like from a size wise, he had to kind of like move tissue out of the way to get a good look at the spot that was on his sort of proximal thigh. And I will say one of the worst smelling skin lesions that I've experienced in a while, and kind of pulled the sheet back and everybody sort of had to take a step back. He had roughly a 6-centimeter area of very tender erythema, and really like not your classic like red, but kind of like deep sort of almost brown to rusty colored erythema. That was indurated and sort of had palpable fluctuates to it, and was draining this sort of like rust colored, nasty smelling fluid. So we hit him through the ultrasound on. And so this is kind of like left thigh coming into groin. And so this shot, that was nothing particularly interesting to me besides just some, generalized superficial cellulitis. Nothing looked particularly interesting in the deeper structure. Panned around to another area and saw this. Anybody take hesitation with this shot?
Where's the little bubbles coming from?
Exactly. So a couple little bright friends here that are kind of floating around. And then this shot makes them even a little more clear and kind of clearly more fluid. And then you got this little like party of air bubbles in here. Now, based on how he looked and the timing of the lesion and the fact that he had sort of a draining spot on him, my sort of betting guess was that this is more like air that had back entrained from this draining site, and was not air that was being generated from within said wound, but certainly that is the scarier of options. And so, not something that I usually see in my standard sort of soft tissue infection abscess. So with that, we felt, while I didn't think it was, felt like we had to sort of go down a road of, more concerning sort of neck fash types of presentation. So we quickly consulted surgery, kind of in discussion with them. We sort of came up with, an overly aggressive and slightly redundant antibiotic plan, which we got going right away, but nobody wanted to mess with him, especially given his underlying diabetes and all that fun stuff. So they were going to take him pretty much straight to OR to debride, and we were sending his labs. White count wasn't bad, had a nice CRP. And of course, in his diabetes, he came back and met, criteria to be considered in DKA, even though he was incredibly well appearing. So with that, he ended up started on like your standard insulin fluid regimen, went to PICU, closed up his labs a little bit while sitting on IV antibiotics, and went overnight that next day for an IND. Ended up growing actinomyces and Prevotella, which are, and did, I think, 2 weeks of PO linezolid on discharge. Didn't actually end up needing to get any more imaging than what we had, and just our imaging in his surgical exam, which I was kind of surprised by. And he actually hasn't been back, and this was, I think, last fall, and he hasn't been back via the ED since, which is impressive given his poorly controlled diabetes. But certainly not like one of those where we see a lot of soft tissue infections, but there was definitely like that little like wisp of something not right there. The next two are actually adult cases to sort of go off of that thematically. This is one of the ones our colleagues had. So 62-year-old coming in with this chronic heel wound, had actually been seen and had a PET scan done for work of a multiple myeloma in the outpatient world, which showed a bunch of subacute air. And so got sent in for management of that. And so this is this guy's soft tissue. So this is kind of like that lower extremity, and sort of different from our friend. You can make out, a lot of sort of cellulitic changes. And if you just kind of catch in here, you have little bits sort of kind of coming in right in here where you've got that kind of hyperechoic, air signature in the soft tissue with some of that sort of dirty shadow behind it. little bit larger field of view, and it's almost like lung shots, you know, like you got your pleural line sitting in here and some of that dirty shadow coming in. You know, things that we don't see as often, certainly sort of complications potentially of sort of soft tissue infections and things that should, you know, having our eyes kind of training for as we're looking around. Similar sort of types of findings. And I have the clinical photo for this, but figured I would spare everyone that shot. It's a 67-year-old male with sort of scrotal perineal swelling and pain, who had a little bit on the white count, was diaphoretic. And they did this ultrasound on him, which, and so this is a fairly classic presentation and appearance for Fournier's. And so you can see, you know, underlying testicle and sort of scrotal anatomy, some thickening of your scrotal tissue, and then a little more obvious appearing kind of bright hyperechoic air signal here, you know, some areas more dense than others and sort of shrouding out behind it. And some you can still kind of see the anatomy behind. But definitely one of those things that, you know, as we're doing our tissue stuff, keeping an eye out for things that may lead to, you know, indications for needs for more than just the standard like Clinton go home sort of thing. Henry, I think I have 2 more in here that I can keep going. Looks like we're about at time.
These are great cases, Matthew. Unfortunately, I have to step away. Thank you so much.
I'll do this last one real quick because it's not particularly complicated.
No, yeah, that's fine, Matt. You can, yeah. So we always run over, but it's up to you.
I mean, this one I've actually mentioned and we looked at recently. It's basically a 14-year-old female, you know, no periods, belly pain intermittently for 6 weeks. I think I've mentioned there's a conversation that when somebody else presented one of these, that mom had interesting, once we told her what we thought it was, threw out to us like, oh yeah, I had one of those too, and had a history of imperforate hymen. Her exam was pretty spot on for it. She had that imperforate and bulging hymen. But as you know, ones that we don't get to see a lot, but are pretty textbook appearing. So large, so sagittal pelvis, bladder sitting here, large fluid filled, you know, fairly echoic fluid into the vagina. And then you can see her uterus has some fluid distension, not to the degree of the vaginal tissue as well. Transverse view, same stuff, big fluid filled vaginal tissue, bladder sitting above that, and you kind of make out uterus coming in here, sort of doubled back over. Let's see what this conversation is. So this girl ended up pretty uninteresting course, got a radiology ultrasound, which shockingly, you know, was the exact same as ours. Did not need to get, was not asked to get any further imaging. You know, there's discussion before about MRIs or not for these. Did not need to do that for her. And ended up undergoing, you know, pretty uncomplicated OR management. And went home. And I'll stop there.
Great cases, Matt. Yeah, I really, the reason I was asking, because I've always been, haven't had that many experience with the blocks, but I feel like I should have do more. So then that's why I wanted to ask your technique to make sure. But yeah, and I don't see as many as you said for like anyone in foreign bodies in the center of the foot. So, but definitely I'm going to try more because I like you said, I just think I just need to become more comfortable with it.
Yeah, I mean, that's mine. Is like, I think it's, you know, and we're also, I think, spoiled relative to our adult colleagues that most of our patients don't have comorbidities. You know, we can put them to sleep at the drop of a hat if we need to. But I think there's maybe not as big a role for it as the adult world has, but I think there's definitely, you know, a strong niche for it. And the more we do it, you know, the nice thing is once you know, they're all basically the same technique. You just know the different anatomy and innervation areas, and then it's not like you need to have, you know, 5 of this one, 5 of that one. You know, they're all end up being basically the same thing, as long as you know what you're trying to block and what the badness is around it.
Agreed. Yeah, well, thank you again. Those are great cases, and thank you for presenting so many. So that was great. So thank you again, Matt. And then thank everyone for coming this week. Next week, I'll be sending an email. We have a chance to have 2 lectures planned. So I'll be sending a reminder for that. But once again, Matt, thank you for presenting.
Sure. Thanks for having me.